Welcome to Put Your Heart Into It, the HVC podcast centered around educating providers and staff about common clinical scenarios so that we can better treat our patients. Podcasts on this account are meant for educational purposes only and should not be used as a substitute for medical diagnoses or advice. If you have any clinical symptoms or medical questions, please consult a licensed healthcare provider.
Today, I am going to walk you through a couple of EKGs, and this is very dependent on the audience. And so the goal of this is to determine if an EKG is an emergency or not. So just by show of hands, how many of you all are providers? All right, so we got a ton of audience participation for this. And so really the only question I want you guys to focus on is the EKG I'm looking at an emergency or not? Do I need to text Dr. Bot to get this person into clinic immediately, or can I send them home and not have to worry about this? I don't have any financial disclosures. I wish I did, but. All right, so first EKG. By show of hands, is it an emergency or is it not? So those of you who think it's an emergency, raise your hand. There's no right or wrong answer. I mean, it's just whatever you think it is. What's that?
I said it doesn't look normal to me.
Okay, it doesn't look normal. Okay, so what about it doesn't look normal to you?
I don't like the QRS progression.
Okay, so kind of a poor R-wave progression. Okay, and then someone said V2, lead 2. What about lead 2? Okay, so kind of smaller QRS complexes. Okay, all right. So this, I would say, is not an emergency. Okay, I would say that this is sinus rhythm, and that you have a first-degree AV block, and that's why you're seeing kind of a long PR interval there. So I would say this is probably okay to leave Dr. Bot alone, outpatient follow-up, no emergency, kind of go from there, okay? All right, next one here. So emergency or not an emergency? All right, show of hands, who thinks it's an emergency? I saw, so okay. So you think it's an emergency? All right, so what about it makes you think that it's an emergency? Okay, so kind of wide, sort of weird looking QRS, right? They don't look normal. What's that? Okay, so a bundle branch pattern block type, and then any P waves or no P waves or, so AFib, someone said AFib. Okay, so this, I would say, is not an emergency, okay? So this is a paced rhythm. So you're seeing, so you're seeing a paced rhythm, which is why the QRS looks weird. And whoever said AFib, that's extra credit. You're right. The underlying rhythm here is atrial fibrillation with ventricular pacing. And so this, I would say, is also not an emergency. Okay. All right, next one. Emergency or not? I hear flutter. I hear groaning. I hear people pulling out Dr. Kakar's number, being like, "Oh no, what happens?" All right. So by show of hands, emergency or not? So who wants to say it's an emergency? So you see kind of that sawtooth pattern, right? So atrial flutter by itself, not necessarily an emergency. Anything else that makes you feel like, oh, this isn't. I shouldn't leave this alone. This isn't normal. So something about the T waves, maybe? What's that? Okay. It's hard to see the T waves because you do have those flutter waves coming through, okay? So that makes it a little bit challenging. So final vote by show of hands, right? So who says not emergency? I see a couple. Who says emergency? I see a couple, and then the rest of you are sort of hedging bets, which is fair. I do that too. All right, so I would say that this is an emergency. And so this is atrial flutter, atrial fib. It's kind of these coarse waves that you're seeing through. But the key here is that it's sort of regular QRS intervals that have no real relationship to these waves coming through. So this is just regularized AFib, A-flutter with an underlying complete heart block. So this would be an indication for a pacemaker, right? So this is somebody who comes to you, you get the EKG, maybe the heart rates are low, you look at it, you say, well, it could be atrial flutter or AFib, but because of that kind of slow, regular QRS morphology, that's an indication, a class 1 indication for a pacemaker. Okay. All right. Here's the next one. So emergency or not emergency. So sinus pause, you're seeing some pause and things are not conducting like they should. Okay. All right. So I would say that this is not an emergency. All right. So I agree that the heart rate is slow and you're seeing these grouped beatings at the end of the strip. And then you see kind of this non-conducted P wave at the end. So this is just a blocked APC or blocked PAC that comes. So you see it doesn't conduct all the way. And so you get these grouped beats, but not an emergency. Okay. So you can have symptoms with PACs, and that may be something that you want to try to suppress, but it doesn't necessarily have to be something that requires a pacemaker. It could be something that you medically manage, but it's not something that you have to send them to urgent care for or the emergency department. Okay, next one. Emergency or not emergency? Okay. Yeah, so it's a slow heart rate, but everything is conducting like it should. You see a P before every QRS. There's no heart block. So this is sinus pericardia. So I would say not an emergency. Okay. Emergency, not emergency. So when you look at it, what about it looks abnormal to you? Okay. So it kind of grouped beating again, right? So they're kind of grouped together in these triplets, and maybe something's conducting, maybe it's not. It's hard to know in between. So I guess final vote, not an emergency. Anyone? Sinus arrhythmia. Okay. So what makes you think it's sinus arrhythmia? Okay. All right. So you see P waves before every QRS. So I would say that this is not an emergency, and it's similar to sinus arrhythmia. It's not quite sinus arrhythmia. This is a sinus node exit block, and the giveaway here is that the distance between the P waves shortens before you have that gap in between the next triplet. And so it is another form of grouped beating. And so the first one that we saw were the PACs. And so this is another form that you can sometimes see on an EKG. It by itself doesn't necessarily constitute an emergency, but that's sort of what you're looking for when you look at that grouped beating pattern. Okay. Anyone want to take a shot at what they think? What about it looks abnormal to you? What about it looks weird or not normal?
Fast heart rate.
Okay, so fast heart rate. And it said something about T waves, inverted T waves. You don't know. You were walking in the hallway and someone just hands you this EKG. They're like, I don't know. What do you think? Should I be concerned? Okay. So you kind of see some STT wave changes. Does it look regular? No. Okay. All right. So that's a good place to start. Does it look irregular? Okay. All right. What's that?
I said it looks irregular. I can't determine any kind of pattern.
Okay. Yeah. So it's sort of irregularly irregular, right? So this is atrial fibrillation, right? This is AFib. By itself, again, not necessarily an emergency, not necessarily something you have to send to the hospital. I'm sure Carlos is somewhere salivating about trying to ablate this. But again, not something that you have to rush to the hospital for.
I have a quick question?
Yeah, of course.
In the context of all of these EKGs,
Yeah.
where do the symptoms play a role? I mean, if you have a patient who maybe had recently a syncopal event, they are very upset about this.
Sure, yeah. So symptoms always play a major role in trying to determine that emergency or not. I think what I would say is even for something like rapid AFib, a lot of times you can send it to the office, refer to the cardiologist, and we can manage that in an outpatient setting without having to send people to the hospital, right? And for AFib in particular, especially if it's new paroxysmal AFib, a lot of those patients will self-convert on their own by the time they see us in the office, right? And so sometimes it can be a lot more stressful to say, let's go to the emergency room, let's shock you, let's do all these things. And then that's sort of what they remember about their AFib, okay? And so I think you're absolutely right? If you have symptoms, that always plays into how you manage whatever it is on the EKG. I think the takeaway from these EKGs, though, is that a lot of the things that sometimes you look at and you say, I'm not really sure, do I need to send them to an urgent care? Do I need to send them, if they are minimally symptomatic or no symptoms, a lot of times those things, other than the complete heart blocks, you can sometimes manage pretty conservatively. Okay, I think this is my last one. So full force participation in this one. Emergency or not an emergency? Hear a lot of murmur. So who wants to raise their hand and say, look, this is not an emergency. Follow up in 2 weeks. What's that? Okay, so why is it an emergency? Yeah, so everything, so you see these P waves kind of running through, right? And they don't really coordinate or match up with the QRS. So there's some degree of what's called AV disassociation, right? The P waves are doing their own thing, the QRS is doing their own thing. And so this is a good old complete heart block, right? So this is, again, a class 1 indication. And so a lot of times they'll come and see you and say, I feel fine, but this is something that needs to be managed a little bit sooner rather than later. I'm sorry? You call them immediately and you say, hey, what do I do about this? But this, even without symptoms, is something that should be managed quicker and sooner rather than later. Any questions for me?
Thanks for listening. Tune in next time for another cardiology-focused episode.